Good afternoon or good evening, depending on where you are, or good morning if you are in the West Coast. Thank you all for joining us today for the 11th of our Colombia CBIPS lecture series on the AEC industry relating to COVID-19. I'm Fenioski Peñamora, Executive Director of Colombia Center for Buildings, Infrastructure, and Public Space, and Edwin Howard Armstrong Professor of Civil Engineering and Engineering Mechanics at Columbia's Food Foundation School of Engineering Applied Science. As the events of the last months have demonstrated, we are living during exceedingly challenging times, characterized by divides, distrust, and distancing. However far apart we have been, however far apart we currently are, we need to learn to come together, to be together, to act together for social, economic, and environmental justice. I hope that the events of these days bring better understanding of the injustice that exists and become a catalyst to bring about real change for all. Along with many of our colleagues in New York City and around the world, the faculty and staff of the Center for Buildings, Infrastructure, and Public Space would like to add our voices to those decrying institutional racism in the AEC industry. Today, our industry has a challenging work ahead to achieve true racial and gender inclusion. We need to stand with our Black architects, Black engineers, Black contractors, Black suppliers, and Black community. We need to listen better, to learn better, and to incorporate the lessons of diversity and distress into the way we all, working together, reshape economically challenged communities. We need to build a better future for our industry, characterized by respect, opportunity, and collaboration. Acknowledging these aspirations and commitments, our lecture program will continue every Tuesday at noon into September with 19 talks from leaders in both the public and the private sectors. These lectures bring people together to address the impact, response, recovery, and preparedness of the architecture, engineering, and construction community in regard to the coronavirus pandemic. These talks also relate issues of social, economic, and environmental justice to the new normal post-COVID-19 AEC world. Our first speakers were from New York, London, Los Angeles, Paris, and last week from the U.S. Army Corps of Engineers based in Washington, D.C. They all addressed different issues related to situations that we have seen that have affected us due to COVID-19, like medical facilities and changes in our office operations. Subsequent talks will focus on the practice of Mark McDonald on civic infrastructure in the city of Sao Paulo, on transportation systems in Chicago, on COVID-19 emergency hospital construction in China, and on design and construction in Seoul. Please check our website to see more information about our next speakers and co-moderators. I also would like to thank the organizations with whom we are collaborating in presenting these lectures. They are the American Council of Engineering Companies, New York, thanks Jay Simpson, the American Institute of Architects, New York, chapter, thanks Benjamin Prosky, the American Society of Civil Engineers, thanks Tom Smith, the Consortium for Sustainable Urbanization, thanks Lance Brown, the Construction Management Association of America, New York, New Jersey, thanks Vinny Fakowski, Engineering News Record, thanks Jan Tuckman, and the National Academy of Construction, thanks Wayne Crew. Today, we turn to research being conducted by engineers at CDM Smith pertaining to the wastewater-based epidemiology. My co-moderator, William J. Nilick III, PE, PMP, works for CDM Smith and is the 92nd president of the New York Water Environment Association, a member association of the International Water Environment Federation. Bill is the youngest person to have held the New York WEA presidency. The New York WEA serves the interests of the public by promoting sustainable, clean water quality management through science education and training. Bill is a licensed professional engineer and project management professional with over 13 years of experience with multiple discipline water, wastewater, odor control, and energy projects. Bill completed his undergraduate degree in environmental engineering from Rensselaer Polytechnic Institute, RPI, in Troy, New York, and his master's degree in environmental engineering from Manhattan College. Thank you, Bill, for being here today. We have two speakers participating in today's lecture. Anna Mehrotra is a licensed professional engineer with more than 15 years experience in all aspects of municipal and industrial wastewater treatment, from process modeling to pilot studies to design. She completed her Ph.D. in civil and environmental engineering at the University of California at Berkeley, and is currently the technical lead for CDM Smith's Wastewater-Based Epidemiology research on predicting COVID-19 resurgences via wastewater analysis. Greta Zornes is CDM Smith's practice leader for water reuse and industrial treatment. She completed her Ph.D. at the Tulane School of Public Health and has over 20 years experience in municipal and industrial water treatment and reuse. Greta spent 3 years in Australia working on the planning, design, and commissioning of reuse facilities, and is past board member of the Water Reuse Research Foundation and the Australian Water Reuse Association. To learn more about them, please visit the CBIPS website. Thank you both, Greta and Anna, for being here with us today. We look forward to hearing your presentation.
Thank you so much, Finiaski. It's great to be here with everybody today. As we're going to talk about COVID-19 and specifically about sort of a rapidly growing field of utilizing wastewater and quantifying the virus in wastewater as a way to track the disease. So very briefly, I want to start out our discussion today with a safety moment. That's something we like to do at CDM Smith. Then I'm going to run through, what exactly is wastewater-based epidemiology, and I'll emphasize that this is really not a new field, but something that's been around for quite a while, but is gaining sort of recognition during COVID as a potentially useful tool. Then I'm going to talk a little bit about research that we're doing, but also other academics and other groups are doing, and talk about some findings that we've all been collecting over the past, really it's only been 3.5, 4 months. And we'll end with time for discussion and Q&A. All right, so to start with the safety moment. One thing, so we're an engineering consulting firm, and we have many water and wastewater utility clients. And I can't tell you how many times a client has asked me a question related to, do we need to be specifically concerned about exposure to COVID in wastewater? Is wastewater infectious with respect to COVID? So that's just what I want to take a couple minutes to talk about here. The answer is we're not 100% certain. This is all research and all ongoing. However, a few different data points suggest that the virus that you're measuring in the wastewater is not infectious by the time it gets to the treatment plant. So one big picture thing to keep in mind here is that I'm going to be talking a lot about quantifying the virus, the SARS-CoV-2 virus that causes COVID in wastewater, and measuring it and looking for it. But actually we need to be very specific about what we're looking for. We're actually, when we quantify the virus in wastewater, we're only quantifying some specific nucleic acid sequences, about 20 bases long, that really give you a fingerprint of the virus. So we don't take the time to figure out, is it a whole virus in the wastewater that is infectious. We're really just looking for that fingerprint. So keep that in mind as I'm talking about analytical methods and the results and all that. That said, it is possible to assess whether the virus that you're measuring in wastewater is in fact infectious, and that involves cultivating the wastewater and looking for signs that the virus is present. Based on what we have seen so far, it's actually very difficult to culture the virus from raw wastewater, although again, that's an area of ongoing research. And it's also difficult to cultivate it from stool. So that's how we shed the virus into wastewater, is through stool. And we're going to I'm going to talk a little bit more about this messy graph on the right-hand side and what that's telling us. But when researchers go in and try to culture the virus from stool, they are largely unsuccessful in doing so. So because the data seem to suggest that the virus is not infectious by the time it gets to the treatment facility, the CDC recommends standard practices are adequate for wastewater and sanitation workers when working around wastewater. And it's important to keep in mind, right, that wastewater is infectious in general. There are a lot of pathogens in wastewater. But those standard practices will include things like engineering and administrative controls, hygiene precautions, maybe specific safe work practices for the particular wastewater treatment facility, and of course, PPE requirements. All right, so I talked a little bit about this question of whether it's infectious, talked about the idea of the fingerprint. We're really looking for evidence that the virus was there, not the whole virus itself. And that kind of leads me to another really important big picture thing to keep in mind as I'm talking through the rest of the slides. And that is that it was not a foregone conclusion that we would be able to measure SARS-CoV-2 in wastewater, because if you think about it, it's a respiratory virus, right? And so this very messy graph that I'm not expecting you to read over here on the right-hand side is showing evidence of virus, the fingerprint of the virus, so the presence of the nucleic acid sequence in the red. There's 3 colors on this graph. Let me just orient you to this graph. So along the top here, this x-axis, we have time, starting in middle of January to middle of March. And then the rows along the y-axis are different patients. And this is from this study here performed in China. So we have about 41 patients. And what they wanted to do is they wanted to figure out, well, where are these patients shedding the virus from, right? This gets to infectivity of the virus and transmission of the virus. And so they looked at patients who were diagnosed with COVID over time and analyzed throat swabs and fecal or stool samples for the virus also over time. So that's what they're plotting here on this graph, and you'll see three colors. One is the red, that's for the throat swabs along, over time. When were they positive for SARS-CoV-2? Yellow is the fecal sample or stool sample. And then orange, it's hard to see, is when they're both overlapping. The big thing I want you to take away from here is, yes, yes, we can measure SARS-CoV-2 in stool, and we shed it, and we shed it actually for a much longer time than we are shedding it in our like a respiratory sample. So anyway, keep that in mind. All right, enough of the safety moment. Let's get into what really is wastewater-based epidemiology. So simply put, it is the analysis of substances in raw wastewater to obtain information on community health. So a couple important things to keep in mind here. We're talking raw wastewater. So wastewater that is either out in the collection system or the sewer system in sewers. And that's certainly one place we can sample wastewater for COVID tracking, but it could also be wastewater that's being collected at the influent to the treatment facility. So it's not treated wastewater. And in fact, studies have shown that most studies have shown, there are always a few exceptions, that by the time you get through wastewater treatment, you're not detecting the virus at all. You're not even picking up on the nucleic acid sequences, the fingerprint of the virus. The other important thing I want you to take away from this slide is that this is not a new science. This is something that has been around for a couple of decades and largely used in Europe and Australia to track many things, but most commonly illicit drug use, because it's possible to measure wastewater and find metabolites of drugs in wastewater. And that's just what this graph here is on the left-hand side. It's showing measurements of four different drugs. I think these were metabolites, this was just 4 of maybe 12 that they measured in wastewater from a college campus in Arizona. So you can see that, it can be used really to estimate sort of the average population level consumption of those drugs. But it's not just about illicit drugs. It's also about exposure to toxics. So exposure to toxic organics or heavy metals, that's something you can use WBE for. Assessment of population level, sort of average nutritional status, and even average stress levels. And even before COVID, WBE has already been applied to tracking viral diseases. The example here on the bottom right shows a graph of a paper from Sweden where the actual number of cases of norovirus that was able to be modeled using WBE and measurement of that virus in wastewater. Another example of application of WBE to viral diseases globally is the using it to track polio. And for example, the Pakistan Polio Eradication Program has an environmental surveillance network, and it's really a network of sample locations for raw wastewater. And they're using that to track where polio has been eradicated in Pakistan and where it still persists. And in fact, Pakistan's Ministry of Health has already used that environmental surveillance network to sample for COVID, for SARS-CoV-2, and they're using that as a way to track COVID. All right, so the idea is that WBE it's not new, it's been around for a while. That said, it's getting a lot of press during COVID in particular. And this goes, and there's a couple reasons for this. And this goes back to what I was talking about on the safety moment slide. We do shed it. We shed the virus in stool basically the day we're infected, within a day or two of being infected. So as I mentioned, that wasn't a foregone conclusion, given that it's not a respiratory virus, that it is a respiratory virus, not a virus that causes gastroenteritis. The second reason it seems to be getting a lot of attention is it has this unique feature that because we shed the virus and it ends up in wastewater just about as soon as we're infected. So that means that asymptomatic individuals and symptomatic people are shedding the virus. And think about when you get infected with, if someone gets infected with COVID, it takes about 4 to 5, maybe 6 days for symptoms to appear. I mean, it can also take up to 10 days or longer, but say 4 to 5 days on average. Then if you're able to detect the SARS-CoV-2 virus in wastewater, because people are shedding it right away when they're infected, you have a little bit of a heads up there, right? And in fact, research has shown that it's not 4 or 5 days. It actually is about 7 to 16 days. That's the lag time between the trends in the wastewater SARS-CoV-2 signal and the trends in new reported COVID cases. And you can think about, just because there's a lot of lag in here, right? You start shedding the virus when you're infected. You start feeling symptoms. You're not sure it's COVID. You won't go get tested for a while. So that kind of explains this lag. And this is research that's been done in a group that we're collaborating with, researchers at Yale and also in Spain. The way that we measure SARS-CoV-2 in wastewater is essentially the same analytical technique that's used to measure it in a throat swab or a nasal swab to detect if somebody is positive for COVID, and that's with quantitative PCR. And this can be with reverse transcriptase quantitative PCR. There's also a lot of researchers looking at droplet digital PCR. And as I mentioned, we do know that the wastewater trend in the signal tends to correlate and even precede that clinical disease incidence. For those reasons, there's been a lot of emphasis on using wastewater testing or wastewater surveillance for COVID as a way to fill the gap that we continue to have in this country and around the world for testing, clinical testing of individuals for COVID. And so I just put some up here, some of the headlines that you might have seen in the news, but it's certainly, the whole concept of wastewater surveillance for COVID was in the scientific literature, the end of March, mid-March, end of March, and then it started getting picked up by the mainstream media, in the middle of April, early April, certainly by May. This is an area of active focus. I'm definitely biased because I read all the articles that come out on this. So I think everybody's talking about this, but obviously there's a lot to talk about with respect to COVID. Some things that are of particular interest are that it's not just an area of research or sort of a research by doing, because there are a number of coordinated efforts around the globe to implement a wastewater surveillance program. So there are national efforts, for example. There's one in Australia. Canada has a pilot test going to see, to try to figure out the best way to implement a full-scale wastewater surveillance program nationally. Finland tracks wastewater weekly in about 28 treatment plants, which covers about 60% of the Finnish population. Germany and the Netherlands also have national programs, and Pakistan, I mentioned, with the Environmental Surveillance Network that was originally set up for polio. And I'm happy to report that the CDC and the EPA are working together now in the US on a pilot program for national surveillance as well. We also know of a number of state level efforts. Colorado is one, upstate New York is another, and Ohio, where the EPA Office of Research and Development is working closely with wastewater utilities there to implement sort of a national, state level monitoring program. I've alluded to the fact that this is a big area of research, a lot of focus right now on methods. Should we use qPCR? Should we use droplet digital? How should we collect the samples? How should we concentrate the samples? How do we preserve them? There's a lot of discussion in that. Also some discussion on trends across, a long time. Longitudinal trends and cross-sectional trends for SARS-CoV-2 signal in wastewater and how that relates to COVID incidents. And also in environmental engineering, there's look into the fate and transport of the virus in wastewater, because if you think about it, we shed the wastewater. There's a lot that can happen between a home where the virus is shed and the wastewater treatment plant influent where the sample is collected, right? You've got interaction with solids, you've got temperature effects, you've got dilution effects, especially if you're in a combined system. So there's a lot of look at that. And so, I kind of check weekly on Google Scholar how many hits you get for SARS-CoV-2 in wastewater. I just checked before this talk and it was another, 1,100. So I checked last week and we've got another couple hundred as of today. So definitely an area of active research. And it's interesting, just talking to folks in the academic world, that I do feel like what's been interesting to see is that there's been a big push to release preprints with COVID and wastewater surveillance and WBE, which has been helpful. And so far, knock on wood, no one has had to retract anything yet. So that's been really interesting. The idea here is that if we can get WBE to work for COVID, and I should pause and say that this is not just about COVID, right? You saw that in the last, couple of decades, we've been developing this technology around the globe, applying it previously to viral diseases. And we do think that this is here to stay for the future. It could be used for seasonal influenza. It could be used for other viral diseases and diseases that aren't caused by viruses. So there's a lot of power in this tool. And if we can get it right for COVID specifically, then the idea is that we can save time and money relative to relying exclusively on testing of individuals. Now, that's not to say that we can measure the virus in wastewater and track it and say, all right, we're done, done with testing individuals. Absolutely not. It needs to be part of a suite of testing tools. But this is just an example on the right-hand side showing from Hart and Halden, this is a group from ASU, where they did a very sort of simple high-level estimate of, look, if you wanted to test all the treatment plants in Germany, say, there's more than 9,600 of them, what would that cost for reagents for SARS-CoV-2 versus testing every single person, right? It's a very high-level comparison, but it does drive home the point that you have to take a whole lot fewer samples to cover everybody or as many people as you can with wastewater surveillance versus individual testing. In the US, we have over 15,000 wastewater treatment plants, and that covers about 80% of our population. So this doesn't apply necessarily to people who rely on septic systems or on-site systems. But, you know, think about taking 15,000 plus or minus tests versus what, 331 million, right? It's a different order of magnitude. Given that sort of leading indicator status of the viral signal in wastewater, it would give time, give time to governments or facilities or companies or universities to take strategic action. And we're still figuring out, you know, what do you do with this information? But the idea would be, say, on a university campus, you're testing the wastewater every day or every other day. From residential halls, and when you see an uptick, and you're also doing sort of random individual testing, but if you see an uptick in the viral signal from a particular residence hall, well, then you could go in and test everybody in the residence hall, or do pooled testing in the residence hall and then get down to everybody. So the idea is you can be strategic about your clinical testing. You can be strategic about quarantine requirements and PPE requirements. And, you know, lockdown is sort of a negative word that I don't think we really throw around all that often anymore. But think about sort of quarantine requirements and moving into new opening phases of our economies. Because ultimately, at the end of the day, the goal here is to keep our economies open, to prevent disease transmission, to prevent loss of life. We're really interested at CDM Smith in the equity implications of COVID in general, and also how wastewater surveillance can be used to understand, you know, the distribution of disease from neighborhood to neighborhood. And that's something that's possible if you're looking at testing in the sewers. All right, all that is to say that to get to the place where you can use WBE as a tool for mitigating COVID, you need two ingredients. And these ingredients are shown here in this orange box. So first, you need to have some kind of confidence that if you're measuring the viral signal, that, yeah, that's actually telling you something about where what you're going to see in terms of the number of disease cases in the next week or two. And then you also need to be able to take the wastewater sample, get the SARS-CoV-2 results, and you need to do it, you make sure that you can rely on that result, it's a good result, and you get it in a reasonable amount of time, right? If the leading indicator status gives us about at least 7 days, it doesn't help to take a wastewater sample and then wait 5 days for the results, or even longer, right? So this sort of orange box is our organizing principle for our research at CDM Smith. And I won't go into just too much detail here because I want to leave plenty of time for questions and discussion. But we have two parallel research initiatives, and one is focused on that first ingredient, which is getting a lot of confidence in the relationship between the viral signal and the disease case, the number of COVID cases. And here we're almost on month 4 of a collaboration with Great Lakes Water Authority. So they run the largest single site wastewater treatment plant in the US. It serves about 3.2 million people in southeastern Michigan. And our academic collaborators are at Michigan State University. It's Irene Zagoraki and her lab. She has a lot of practice quantifying viruses in wastewater. And this is a big system, so there's going to be a lot of statistical analysis needed to kind of connect the dots between the viral signal and the disease cases. But we're on our way, and we just submitted a revised manuscript to the Journal of Environmental Engineering with our results to date. And that will be the next step, is to move into the model to connect the dots. The second one is something that, you know, might be more on your minds at Columbia, and that is we're also doing research at a smaller scale. And we call it the facility or a site-specific approach. And we're doing a pilot with Brown University, where we are, as I was talking about, you know, sampling at residence halls. We're setting up auto samplers at residence halls, about 10 locations on campus, and we're proving out a rapid qPCR method. So this is based on a field qPCR kit. Field is a little bit of a misnomer because you need a whole bunch of other stuff to go along with the qPCR kit. You need a couple different kinds of centrifuges and a water bath and some other things. It's not like you can really sit in the field and do these analyses. However, the equipment you need is reasonably portable, and the kit should give results within a day. So that's what we're working on here, but this isn't just applicable to universities. You know, we've talked to the military about using this on aircraft carriers or on bases, large industrial facilities where you have a large concentration of employees in a relatively small space. Certainly nursing homes and prisons. These are the sorts of places where, you know, you could be sampling the sewer, and if you can get the result quickly, you can use that information to apply, you know, strategic use of your clinical testing. I believe these slides will be shared with you all and available after this talk, so I won't go into too much detail. It's a lot of numbers on this slide, but just to point out that there are a number of research groups measuring the virus in wastewater, and some things to keep in mind, and I've just highlighted our research group here in orange. And this is not meant to be a comprehensive list, but these are some of the studies you might have heard about. One thing to keep in mind as you're thinking about this field and reading literature and the news is that we don't have it figured out with respect to what type of sample should we take. You know, I talked about 24-hour composite samples and auto samplers for Brown University. Well, you know, maybe you can also take grab samples. And in fact, that's what we're doing in Detroit. Although they're very large grabs, they're 20 to 80 liter grabs in the sense that they're filtered like on site. So we're still figuring out, you know, what sample volume do you need? How should you process the sample before you get it, you know, to get it ready for qPCR? Because if you think about a clinical sample where you're taking say a throat swab, it's a relatively clean sample. And if that person is infected, there will be a lot of virus in that sample. So that's pretty easy to find a lot of virus in a clean sample. Well, wastewater is the opposite, right? It's a dirty matrix with very few virus genome copies per liter, relatively speaking. So there's a whole bunch of different ways to get this, you know, clean up the sample and get it ready for qPCR. And that this whole, you know, this whole table is the topic of a Water Research Foundation proposal project, and the topic of many, you know, research groups. And then you can also talk about qPCR, right? But what is your target? Which 20 base sequence are you looking for? The CDC recommends 2 in the nucleocapsid. Other groups will look at different ones, and I think the World Health Organization was originally recommending, I believe, something in the envelope and in the nucleocapsid. I'm not up to date on what their latest targets are, but another thing to keep in mind, and these will give you different results because I think they tend to degrade at different rates, or it's not clear. So lots to keep in mind when you're interpreting literature, research articles in this area. You know, the ultimate goal, right, is to get this to work, to apply the tools so you can use it to predict disease, so you can avoid disease, right? There's a lot to think about here, too. Are you going to try to correlate the wastewater signal with cumulative number of cases to date or new cases, right? Are you, you know, how does your sewer shed or collection area or service area for your treatment facility line up or not with the scale at which health data is available? Here I'm showing the Great Lakes service area. It's in green, and you see it has some sort of areas cut out because there are other treatment facilities in there. And I don't know if you can see, but the city, well, the counties are these larger, you know, lines here. And sometimes health data is available at the county levels, county scale, and then townships and cities are at these, you know, smaller gray lines. So, you know, this doesn't match up with the green, right? So you have to go through this exercise of really, ideally, getting health data, so COVID cases at the zip code scale, and then matching the zip code to the service area. But you can introduce a lot of error when you're going through that process. And then, you know, some groups have tried to relate in very kind of simple terms the viral signal with the number of cases, and sometimes it matches and sometimes it doesn't. You know, there was a paper that was widely read about Boston wastewater, where the researchers estimated that the prevalence of COVID in the community might be 0.1 to 5%. That's a big range, versus 0.026% reported. Now, this was a while ago, so these numbers are obviously larger now. So just some key takeaway themes before we get into questions and discussion. I talked earlier about how WBE is not new, and we really feel like it's here to stay. It's applicable at the city scale. If you're talking about measuring, just raw wastewater at the influent to a treatment facility, you can also talk about going out into the sewer system and collecting in the community to capture, the health of specific communities. It's also something I talked about can be used at the facility scale. I gave you the example of Brown University, but some other facilities that might be suitable for this tool. And I also talked earlier about how this is not just about COVID. Obviously, right now it is very much about COVID, but if we can figure out these tools now and set ourselves up to use this could come in very handy sort of during future global health crises. I would encourage you all, if you're interested in COVID and WBE, to go to this link here. This is the Global COVID-19 WBE Collaborative. You can join this and get on a Slack channel and a protocols channel if you want to, kind of stay up to date. Keep track of the CDC and EPA National Wastewater Surveillance. And I would also say, if you're interested, keep track of the results that come out of the Water Research Foundation methods, project. Okay, and with that, thank you so much for your time, and I will turn it over to Bill.
All right, so now we're going to get into some questions. One of the questions that we received during the registration process was if there will be any jobs becoming available as a result of these new initiatives that are going with testing of wastewater. So I guess Greta or Anna, do you have any insight on that, please?
Yeah, we talked about this before, and because I think it's a great question, because I do see, if we can prove this out, and we've got, that we move from pilot to full-scale national wastewater surveillance, we will need a public health corps essentially to help collect samples, because wastewater treatment facility operators already have plenty to do in terms of collecting samples for compliance with permits, right? So we do see that this could be a whole new job category, but who knows? I don't know what the intention of CDC is.
I just want to thank you, Anna, for such a wonderful and informative presentation. And it's quite interesting that you are looking at this work and giving us some heads up of what is to come, and give us, and I think what you're saying, maybe 7 to 16 days look ahead. And particularly if we're thinking of the preparation for hospitals, our emergency personnel, the procurement of PPE and any other critical medicines. I think it's quite interesting. And what we have received is a couple of questions in terms of when you look at the technology and the procedure and the standards that are being used to measure this for COVID. And you say that it can be used for other type of pathogens or other elements. Is this something that is a standard both across the United States and internationally, or are there differences between countries? I know you mentioned Germany and other places. Is this a standard throughout the world?
Yeah, I would say not yet. We're all doing it sort of our own way, even state to state in the US, but I do think we're heading more towards standardization of this approach, and that will be one great thing that will come out of all this COVID research. So it's a great question. We're not quite there yet.
Okay, thank you.
Another question. So I know testing at wastewater plants is a nice sort of like a point source to be able to grab from a bunch of different areas that are all kind of congregated into one spot. Can you do this on a smaller scale, like with buildings or nursing homes or hospitals, to maybe centralize it, or not centralize it, but to hone in a little bit more at a specific area?
Yeah, absolutely. As I was mentioning, you know, we're doing the pilot with Brown, so that is a much smaller population. I think they're planning to have 2,600 students on campus, plus, you know, some faculty and staff for the first term in the fall. So it's much smaller than the 3.2 million people in Detroit. There was actually just an article that came out from a group of researchers in Australia last week talking about using it for cruise ship surveillance. And actually airplane surveillance, and they looked at 3 flights and measured the sewage from those 3 flights. I think the largest one had 185 passengers, and the smallest had on the order, you know, fewer than 100 passengers. So I think the jury's still out on whether that's the best application, but yes, certainly nursing homes where you might have 150 residents, prisons where you might have over 1,000. Those would be, I think, all really great applications.
Oh, that's quite interesting. Again, you can look at the different locations and identify any patterns that may occur. We also have a question from Julia Kaust from Helsinki. She mentioned that in Finland, I don't know how familiar you are with Finland and the situation in Finland, but it seems, she said that it seems to be doing well with the diagnosis of cases. But as the schools are starting up in mid-August, there is a concern that it takes a long time for the data from wastewater samples to become available. Could you speak a little bit about the lag from in terms of that data availability and having people, decision makers, to use it for informed decisions?
Yeah, Greta, do you want to take this one? Because I know you had some conversations with some commercial labs who are trying to tighten up that turnaround time. Yeah.
Sure. Yep. Happy to do that. So as Anna said, we've been working with some commercial labs. We're trying to work with them to understand what we can do in the field to make the processing of these samples quicker once they get to the lab. So we're working collaboratively with a couple of them to try to get those sample turnaround times down to, you know, about 24 hours. But then also, as Anna mentioned, we think one of the other keys is being able to do this testing in the field so that you get the same day results. But certainly, if you're working with an academic institution, we have found that sometimes it can be very difficult to get that sample turnaround time that you need, and then you lose that benefit of the 7 to 16 day heads up.
And how long it takes normally now? How long is taking for the turnaround?
Right now, we're seeing about 5 days.
Oh, okay.
Yeah, it can be done quicker, maybe 3 days with one of our commercial labs, but, you know, really reliably.
Yeah, 5 days to a week, I would say. Yeah. Or
okay.
Weeks. It can also take weeks, right?
Okay,
Yeah.
so that in that case, as Greta was mentioning, that takes away some of the heads up that you
Absolutely.
could potentially get it. So very good question from Julia from Helsinki. Bill?
Sure. So I see another question has come in from Alexandra Wagner. So obviously the data that comes in when you're going from a wastewater plant or even like a common stream, it's diluted and it has many people's input coming in.
Right.
And so is the data a little bit less usable because it's as opposed to testing the source that it's coming from, you're testing from a diluted factor. So it kind of makes it a little bit more difficult to pinpoint where it's coming from and what you can do about it. And I guess, is there anything you can speak to that or any solutions to that?
Yeah, it's a great question. And so that's kind of why we didn't really intend to make it difficult for ourselves, but when we partnered with MSU and GLEWA, we realized that's really a worst case because you're talking about 3.2 million people flushing their toilets in a very large, leaky, old collection system. So lots of infiltration and inflow, lots of dilution of the sanitary flows. So a couple thoughts on the question. The first is, it's absolutely possible still to quantify the virus, even in such a dilute flow. And Irene, our collaborator at MSU, had previously used these methods to track hepatitis A in Detroit and was able to detect an uptick in 20 cases of hepatitis A in this service area of over 3 million people just by tracking it in wastewater. So it's sensitive enough if you are using the right methods. the second thing is, yeah, you're talking about measuring it in the sanitary flows, not in the stormwater or the, the whatever you're diluting your sanitary with. So then you can ask the question, well, do we really know how many people, how strong is the wastewater? You can actually back out the population contributing the wastewater by tracking biomarkers. So things like there's a creatinine is something that we all excrete, not exactly at the same rates because it does depend on muscle mass, but you can estimate, if you track creatinine, you can then back out how many people are really in the service area right now. And then the third part, I think, to answer that question is it really depends on what you're trying to do, right? Like if I'm the city of Detroit or if I'm the state of Michigan, I would want to be tracking it at a large scale, but I'd also probably want to have a plan. So for example, we're working with USAID in Jordan right now to implement a monitoring program using wastewater for COVID. And the idea is we're very regularly monitoring and measuring SARS-CoV-2 at about 4 places in this one area of Amman that we're looking at. If we get a hit, if we get a detection or an uptick, then we have a plan for where we're going to go upstream in the sewer to 4 additional places and try to figure out where is that coming from. And then we have another plan to go up from there. So you got to get the results quickly, right? So you can take action. So it's all part of the deal. But yeah, absolutely. I think it's possible to start at the wastewater treatment plant. So.
Oh, that makes sense. Thank you.
Okay. There is a question that is coming from actually one of our past co-moderator, Vinny Fakowski, the president of CMA New York, New Jersey. In terms of the technology and the approach that you're using for COVID-19, how well is equipped to detect any future pandemics? Now that you have looked and you kind of presented the uptake on the interest and the work, even though this has been around, how quickly can this be adapted to others unknown pathogens that you will like to detect in the future?
Yeah. I think I don't know, Greta, if you want to speak to that, or I don't want to put you on the spot, but we want to hear your voice. I'm sure people are tired of hearing me talking.
No, Anna, you can add. I guess I'll say just quickly that yes, we certainly think that this could be used in the future, not only for other pandemics, but particularly in places where we do direct and indirect potable reuse of wastewater. So in that field, it's really important for us to understand, how that viral loading that we get to our systems. So that's another application of this knowledge and technology. So of course it would depend on the type of pandemic it is, but assuming that it is excreted again in stool and that we can measure it in some way with a quick turnaround time, then yeah, understanding the collection system, understanding the inputs, understanding how you measure virus and the different influences, you certainly could apply it to other pandemics. Anna, any other?
Yeah, no, I think that's
adds
great.
To that?
No, that's it. I mean, there's a lot that goes into connecting the viral signal to the number of cases. And so that information is related to things like what we know about how the virus is shed over the life cycle of the virus, sort of the incubation period, general health of the population. Some of those things are going to be virus or disease dependent and some of them won't, but it would be a matter of updating those models, updating your methods to look for the virus in question or the disease in question rather than COVID, but the whole framework still applies.
And how long it will take to adapt? Like for example, for this case, for COVID-19, how long did it take from the time that you thought, okay, we can use these methods to detect and start getting results that were meaningful?
Yeah, so I would say that one of the first papers that came out was out of the Netherlands at the KJR Institute, and that was the middle of March, I want to say. So couple months, not much longer. Yeah, I mean, we're still figuring it all out.
Yeah.
But we measured it in wastewater quite early on. Yeah.
Are there, I know we kind of dump a lot of things into our sewers. Are there anything specific or general even that homeowners or other, I guess, inhabitants might dump down their drains that kind of inhibit the measurement or keep you from getting accurate readings of the virus in the wastewater?
Good question. We were just talking about that in the context of some industrial clients who might combine sanitary flows with industrial flows, and in those industrial flows, you might have, variations in pH. You might have some cleaning chemicals periodically, and the answer is we don't know for industrial wastewater whether that would have an impact. For municipal, given how frequently we are measuring it and quantifying it in wastewater, there doesn't seem to be one particular inhibitor that we can't get around in municipal flows. So, but something to think about if you're, measuring somewhere and you're consistently not seeing hits, but that there are people infected with COVID, that would be something to look at, certainly.
Okay, thank you. We have another question that came in. It's not necessarily to COVID-19, but looking at disaster in general. And I think Greta, because of her work on reuse, may be able to answer. And the question comes from Heather Phillip O'Neill. She is the past president of NOMA, the National Organization of Minority Architects. And her question is, can water be reused after a disaster such as Hurricane Maria in Puerto Rico or earthquake in Haiti?
It's a good question because it depends on the situation and the water quality after the disaster. But the short answer is that water can almost always be reused, assuming that you select the appropriate treatment for that water. So it's all about having the right treatment selected for it. And you can do advanced treatment. I actually live in New Orleans, and I know after Katrina, we had a lot of reverse osmosis systems, brought in to help improve our water quality at certain locations. So yes, it certainly can be done. It's just a cost and a logistical challenge. And sometimes power as well. Yeah.
I guess one question that I had is that, do you anticipate there being any sort of, design standards or implications being incorporated into future designs to either ease sampling or to kind of make this process go a little bit easier, for example, potentially in the fall or some other time when a second round of this happens or some other sort of pandemic in the future? That's kind of a general question.
Do you want me to go first on that one?
Sure, yeah.
I don't know about a design standard, but I can say that we are certainly working on some inline detection methods that would allow us to detect the virus real time. Now, this will take time, obviously, but it's, again, something that maybe could be applied in the future depending on how quickly we get this work done. And again, as I mentioned before, it's all applicable in the world of direct potable reuse. So, Anna, any additional comments?
You got it. That's great.
We also have a question actually from a former colleague and a really dear friend, Shah Jeromi. He's the Associate Commissioner of Infrastructure at the Department of Design and Construction here in New York City. And his question is, what is the level of danger to being infected with COVID with construction workers who are directly dealing with installing sewer pipes and connecting pipes to live wastewater flow? I don't know if you or any of you may have some ideas about this.
Yeah, no, I think the answer to that is sort of similar to what wastewater treatment workers need to deal with on a regular basis. And again, the answer is we don't think that SARS-CoV-2 is infectious by the time it ends up in wastewater. Is that because when we excrete it, it's no longer infectious, or something happens in the sewer to make it uninfectious? We don't know. But I would say as long as you're following sort of standard safety, safety protocols with respect to working in sewers, and certainly, PPE, gloves and masks, then, we should always treat wastewater as a generally pathogen-containing substance, because it is. So if we continue to treat it that way, we don't expect that it has a special risk with respect to COVID.
Another question that we are thinking is that now we do have presenting how looking at the wastewater can be almost like the canary in the coal mine and give us ahead if we are able to shorten the time for the test to give decision makers enough time to be prepared. Do you feel that there is going to be more investment on infrastructure in the wastewater to equip them to better serve that function in addition to treating water, but help us in terms of the warning signs for any potential public health disasters?
Yeah, if we can get, and I'll just tee this up and then Greta, you can take it away, but if we can get, some of these online sensors that Greta was talking about, validated, and we can kind of take one more step towards digital water. So where we're tracking water quality and quantity in more real time, and we have a good, dashboard or tool or interface by which to do that, then yes, I feel like this could help us move along that digitalization, sort of path. I don't know what you want to add to that, Greta.
I guess I would just add that unfortunately, wastewater is often not well funded. It's one of those things kind of taken for granted, like everybody expects, and especially in North America, that they flush their toilet and it goes away and they don't have to ever think about it or deal with it again. So maybe we can use this to help raise the profile of wastewater and the value of wastewater, because there's actually a lot of other information in there. So it's not just, what we're talking about today. There's a lot of data that exists in wastewater about our populations. So it's actually an interesting topic that maybe this mainstream press about wastewater will eventually help our funding and end up, leading to more innovation around wastewater.
Yeah, I think just one thing to add to that briefly is that on the news and other media outlets, it's very clear that essential workers are highlighted many different times, working in hospitals, working in even grocery stores and other places that we all need to frequent. But one classification of essential workers that isn't discussed barely at all, maybe in our circles, is our wastewater workers, water and wastewater workers. And we all expect the water to work when we turn it on, and we expect the toilets to flush when we need them to, but we don't necessarily think about where it goes. And those people still need to show up to work and make sure everything's working. So yeah, I think raising the profile a little bit of that classification of job workers is very critical to making sure that all this works as smoothly as possible.
Yeah, well put.
Yeah, that's a really great point. I know in a lot of cities, it's been, the decision was made early on that because of the importance of keeping your hands clean, people's water could not be shut off. So regardless of if they're paying their bills or not, water service could not be shut off during this pandemic. So again, you're right. These are critical workers, essential workers, and we haven't recognized them, unfortunately.
Thank you, and definitely very good points, and they are providing a very important service, and they do need recognition and the investment necessarily for them to do the work to the best of their capabilities. Well, I just want to say thank you so much, both Anna, Greta, and Bill, for this presentation and moderating and the questions. It has been very informative, and thank you for sharing this with us. We would also like to thank again the collaborating organization, ACEC New York, AIA New York, ASCE, CMAA New York, New Jersey, CSU, ENR, and NAC, the National Academy of Construction. I would like also to thank our past speakers and past co-moderators who have joined us today. Eric McFarlane, Deputy Commissioner of Infrastructure at the New York City Department of Design and Construction. Eric Borstein, Associate Commissioner for Public Buildings at the New York City Department of Design and Construction. And I already mentioned Chad Jerome, Associate Commissioner for Infrastructure in New York City Department of Design and Construction. I also would like to thank Heather Philippe O'Neill, past President of the National Organization of Minority Architects, Lance J. Brown, our collaborator a collaborator from CSU, Jackie Snyder, Vice President at ACOM and former Senior Advisor for Infrastructure for the Office of the Governor here in New York. And of course, Vinny Falkowski, President of Construction Management Association of America, New York, New Jersey. I really would like to give a shout out to Vinny. He was the one that suggested this topic for this presentation and this lecture, and definitely it was a great topic for us to hear. I also would like to thank especially to all of you out there in offices, agencies, and at home throughout New York City and around the world for taking some time to listen to our lecture today. An AIA Continuing Education credit has been requested for this lecture. If you are an architect seeking credit, the Eventbrite registration allows for indicating your AI membership number. If you did not submit that information at registration, please send your name and membership number to us at cbips@columbia.edu. I also would like to thank our team here at Columbia's Center for Buildings, Infrastructure, and Public Space, Michael Smith, Charles Cheng, and Rick Bell. I can tell you we will not be able to do any of this without their help. They are the heroes here. Next Tuesday, on July 28, also from noon until 1 p.m. Eastern Time, we will have the 12th lecture in the series. Our guest speaker will be Nicholas DeNicolo, President and CEO of McDonald North America. My co-moderator will be Patrick Natal, the former Executive Director of the American Society of Civil Engineers and the Executive Director of the United Engineering Foundation. On Tuesday, August 4th, the 13th lecture in the series will be given by Victor Ali, responsible for the infrastructure program of the City of Sao Paulo. My co-moderator will be Luis Carlos Pinto da Silva Filho, Dean of Engineering at the Universidad Federal do Rio Grande do Sul. The speaker on Tuesday, August 11, the 14th lecture in the series will be given by Gia Biaggi, Commissioner of the Chicago Department of Transportation. My co-moderator will be Nora Elgari, Vice Chair of the American Society of Civil Engineers Construction Research Council and Associate Professor at the University of Illinois, Urbana-Champaign. Then we go to Asia, where on Tuesday, August 18, the 15th lecture in the series will be given by Dr. Penchao Xu, Chief Engineer, China Construction Third Engineering Bureau Group, the team that built the hospital in Wuhan in a week. My co-moderator will be Fang Dongping, Dean of the School of Engineering at Tsinghua University in Beijing. And the speaker on Tuesday, August 25th, the 16th lecture in the series, will be given by Buk Nan Lee, Professor of Seoul National University. My co-moderator will be Munsu Park, Professor at Seoul National University. So you will see the variety of speakers that we're going to have from South America and Brazil to Asia to Chicago. All are sharing their information of what they are doing in this very important topic. On our website, cbips.engineering.columbia.edu, you can find information about past speakers, including the PowerPoint presentations and video recordings of the talk. You can also find information about upcoming lectures in the program. Recently added to the websites are thoughts about reopening of workspaces, and in addition to ideas about the reopening of restaurants and bar space. A case study shows how this is happening at the Black Rabbit in Greenpoint, Brooklyn. Thank you, Anne and Ken Lanier, and architectural designer Maria Morrison for their contributions. With all of that, I really would like to thank all of you for joining us today, and stay well. Thank you so much.